All right, I think we'll go ahead and get started. Good afternoon, everyone, and happy EMS week. My name is Jess Delaney, and I'm the training manager here at Mount Sinai. I'd like to thank you all for joining us on this Safety Tuesday of EMS week. We're excited to have the Selikoff Centers for Occupational Health joining us today to give a presentation on lifting and moving for EMS providers and how to prevent injuries. It's my pleasure to introduce Arlette Loeser. She's an ergonomist and expert in safe patient handling, and she will be joined by Michael Gormley, a clinical nurse manager who does a lot of work in upstate New York and New York City. We will have an opportunity for Q&A at the end of the session, along with a brief survey for you all to fill out. So with that, I'll hand it over to the Selikoff Centers.
Thank you, Jess. Welcome, everyone, and happy EMS week. We're really happy you're signed up for this webinar today, and we're really hoping that you'll walk away with some really good practical information that you can apply on the job when you're back, whether today or tomorrow. I am from the Selikoff Centers for Occupational Health, and my co-educator is Michael Gormley, who'll be signing on shortly. And a little bit about the Selikoff Centers for Occupational Health is that we are a clinical center with 4 locations. We are out of Mount Sinai Health Systems, and we do a lot of work with individuals who have workers' comp-related injuries and work-related injuries and illnesses. Our mission is really to keep workers healthy and their workplaces safe. We also help individuals, all of our patients that have workers' comp management challenges, and we help them coordinate benefits. And our physicians are really a stellar team, and we are multidisciplinary. I'm an ergonomist and an occupational therapist, and I work with many of our patients with musculoskeletal injuries. So today, just to go over some of the objectives that we have, we're going to do a safety case review so that we can examine the ergonomic exposures related to this case. It will be about navigating stairs out in the field, and we'll touch on that and look at the exposures related to stairs. And incident reporting, we'll touch on that as well, safe patient handling, lifting and moving, slips, trips, falls, and drops, and also a little bit about building a safety culture. Before we jump in on the more technical aspects of the webinar, I always think it's good to take a look at the statistics because I find the numbers staggering. And this is actually data from 2017 from the CDC and NIOSH. Unfortunately, it's not updated as of yet, but it's a good indicator and a way to get a benchmark of what we're looking at. So it's really interesting to find out that the providers, the responders that had the most injuries are ones who are working less than 10 years, and they're full-time workers. So what that means to us when we started this program was to make sure that we would include the onboarding time frame so that new EMTs could and paramedics could really have a chance to learn before they're out in the field or while they're out in the field initially, and really to give a foundation of knowledge. We also do refresher training, but we thought it was important to target that statistic. With 22,000 EMS workers, like in 2017, who had visited EDs, we're really looking to lower that number. And also our goal is to decrease the severity of the types of musculoskeletal injuries that occur. So the type of injuries that occurred the most are sprains and strains, and mostly at that time it was to the back and neck. Over time, the numbers have inched up in terms of shoulder injuries and knee injuries as well. And the injuries were occurring mostly from 911 calls, and it included patient care and transport. So, just keep these statistics in mind because, of course, none of us want to be a statistic, but we also do encourage all responders and anyone in healthcare to get attention quickly. And we'll talk about that a little bit later. So today's safety case review, I'm going to start by building the scenario. So we have an EMS crew who is responding to a call 9 p.m. at night, so it's dark, and it's for a 78-year-old male. He fell, status post of fall in a one-bedroom apartment, um, and it's a five-story walk-up. The patient lives on the ground floor, but there still are 8 steps to exit the building on an outside stoop. So it's probably a brownstone of some type. And there were no additional resources on the scene. Continue to build the scenario. The EMS crew utilizes Stryker Stair Pro, which many of you are familiar with, which has a track system that helps in terms of decreasing the amount of lifting required, although it still does require physical effort and exertion. They secure the patient in the chair and they move the patient to the top of the stoop stairs. And the patient weighed about 180 pounds. So start to build this image in your head of this is what happened. EMT 1 at the bottom of the stair chair was carrying the trauma bag, backpack style bag, not unusual, with an insert to carry the AED. And the estimated weight of the bag was 50 pounds. EMT2, who was at the top of the stair chair, was carrying the airway bag, also a backpack style bag containing an oxygen tank and various airway related equipment, pieces of equipment, and the estimated weight of that bag was 40 pounds. So in your mind, please start building the scenario. So what happened? EMT1 and EMT2 were facing each other while carrying the patient down the stairs. Remember, this is outdoors, it's dark, and there's a stoop. Okay, so those are key elements because that changes how secure, it changes the exposures, the risk once we're talking about nighttime and we don't know how well lit the area was. EMT1 at the bottom of the chair missed the last step, unfortunately, and fell with the patient and the stair chair to the ground. EMT1 reported knee and back pain after falling and also sustained minor abrasions. And the patient complained of jaw pain from landing face first, and the crew applied a cervical collar. Backup was requested, and the patient was transported. And EMT1 was seen in the ED for minor injuries and stated after the visit that they would be ready for work at the next scheduled shift on that Sunday. So, what happened to EMT1? What was the injury? Um, they reported a feeling of strain in the back and the knee and minor abrasions. After triaging the patient, reported the injury to the supervisor and was advised to fill out an incident report and to be evaluated. Also, the final diagnosis was muscle strain to the low back, a knee contusion, and scrapes to the palms from the impact to the floor. So this should give you an image of what happened. Um, People miss steps. It happens all the time. It's even harder. People miss steps even when they're not carrying a patient down the stairs, let alone when you're walking backwards going down the stairs. So the risk is great. And this is why we chose this incident to look at, because we know that even with a lot of experience and best practices, sometimes things happen. So, you all may have different types of stair transfer devices, stair chairs. Um, we're choosing the one that was profiled in this case, and the techniques and the body mechanics are relatively the same, but things change a little bit depending on how heavy the stair chair is and what you have to be holding onto. So I encourage you all to go back to your practices and to apply what you learned today, or you may already know, but to refine what you learned today in order to use it on your equipment with your team. So in the ergonomics world, we talk about exposures, right? We talk about this in terms of safety. We talk about it in terms of infection in the healthcare world. What are the ergonomic exposures related to carrying a patient down the stairs? So Some of you may say, oh, I know this, I know this, I know this. And that is true. But this is an opportunity for you to think about this without the pressure of your job and to think about what you can do differently or to do better or to communicate to newer responders. Or if you're in a teaching position, it's really helpful. Um, but we don't often have the opportunity to sit and to really analyze and take apart what's going on. So the ergonomic exposures that we've identified are the unpredictable weight shift of the patient while they're on the stretcher or in the chair, in this case, in the chair. The movement of the equipment bags do impact body postures, right? If the bag starts sliding to one side, we have to compensate for that. Uh, Also, I will, since we're talking about body postures and the impact, not just the equipment bags, but we're also talking about rounding a corner. If, let's say, you're going down a few flights of stairs and you have to turn a corner, oftentimes you'll have to tilt a stretcher or a chair. And then again, you have to compensate with your body strength. So even strength on your body is key. Had to slide that in. Communication of the partners on the steps while carrying a load. So communication is key. We tend to focus on that quite a bit in our teaching because we think that can prevent incidents quite a bit. And then on the stairs, the distance, how many stairs, um, how do you how do you how do you decrease the risk? But it is an exposure, that last step miss. How many steps are there? What can you do to compensate for that? And again, if you have someone who's going down backwards or forwards, there still is risk involved. So we also looked at it in terms of, okay, the bottom of the stair chair and with the top of the stair chair. So the bottom, EMT1, going back to our case, can be pushed off balance if the stair chair alters position. So if the patient moves, if the bag moves, if you have to turn the corner. There's a higher level of physical demand in terms of stabilizing the stair chair when you're at the bottom, right? You are the anchor person. And the top of the stair chair, EMT2, can be pulled backward going up the stairs when they're facing the next landing. Center of gravity and how you compensate for that when your feet are next to each other on the stairs is very difficult. And also, EMT2 at the top can be pulled forward if they're facing the patient. So, there's a lot to be looking at here, and we're going to do that in just one moment. We know that there isn't just one way to manage a stair chair. We know that some people learn to do it when with the partners facing away from one another. So let's say the bottom person may be going down foot first and not seeing their partner, not going down backwards or going up the same way. We've seen that some of the manufacturers show that in their videos. We've also spoken to different EMTs and worked with some and taught. And we decided it's important to express that there is more than one way to do this. The video that I'm going to show you is of the two responders facing one another. And this is generally how this is practiced out of our health system. But we know that there is not only one way. So just give me a second and I'm going to start the video. And, even looking right here, right now at the video and seeing the bottom EMT1, we'll call him, right? The bottom responder, that you see one foot on one stair, one foot on the other. And when you're in this position, as you know, you really have to think about so many things. You have your patient in mind, you're facing your patient, you're communicating with your partner, you're also feeling the step as you go down. Maybe perhaps I know one of the best practices that I recently learned was the idea of kicking the step in order to help with the count and also to make sure the step was viable, to make sure that it was not broken. And we're going to start the video now so we can take a closer look. Here we go. So we have EMT1 who just walked down. We have EMT2 who's still at the top. Okay, so whoops, here we look at EMT. Here we look at EMT2. EMT2 at the top. Let's just watch his positioning because look at his arms. He's holding his elbows out and now he's stepping down. Okay. And EMT2 at the top is really pulling his body back, his center of gravity back. Now, this is part of practices. We know that you do this. The question is, how can you do it without risking injury? So this is where, when we were shooting this video, it was really important for us to note that going down a flight of stairs sometimes requires a break. Sometimes, balance is not great, or someone played baseball the day before and they're coming in a little jelly-legged. We want to pay attention to all of this, and this is where partner communication is key. So, you know what, EMT1, I played baseball yesterday, and my legs are a little wishy-washy. I've got this, but just let's go slowly. If you look at EMT1 at the bottom, you'll see that he has 1 foot down, 1 foot up, and you see his elbows because we don't want to just look at the legs. We want to see that he is stabilizing, right, guiding the chair as it goes down, but really anchoring it. And he's an elbow flexion and he's using a lot of his shoulder musculature. And also, in order to see, you see his head is tilted to the side. I mean, this is what you all do, but it's kind of nice to look at it and be able to analyze it from the outside. Okay, whoops, this keeps happening. Sorry about that. Um, hmm, Bear with me 1 second. We're just going to go down. You get a chance to look at this again. It's like a rerun right before your eyes. So just take a look at the elbows, look at knees, look at twists. Okay. And now we're getting a little bit closer. Okay, so what we see here is EMT1 at the bottom, while his elbows initially were bent back, as he gets down lower to the bottom stair, his arms are now in almost full extension. And what we do know is that full extension is not really great for the shoulder capsules or for the elbows. So we always want to include a little bit of, even a few degrees of bending at the elbow in order to be able to rely on your biceps muscle because they are so strong. And we look at EMT2 at the top, and you see that walking down, you would think he was straight, but actually he's a little twisted to his right side. So this is it's all excellent practice, but this is where we see the risk, so we want to pay attention to it. Okay, let's continue down to the bottom. Okay, so let's look at EMT1 again, and you see where he is bending. You see how he has a wide stance of his legs, which is really protective. That helps build a foundation of strength. My hope is if I was teaching him and we were working with a class or responders, we would talk about what you can do with your core muscles as you get to that point. He's really in a semi-squatted position. And anyone who does this on a regular basis, let's say for their own personal exercise, knows that's a tough position. And when you do a semi-squat, you're not doing it worrying about a patient on a stair chair. And then you have EMT2 at the top who is leaning forward, bending at the back, right? So I'm hoping he's contracting his core muscles, his abdominal muscles in order to build a strong foundation, and also doesn't have his arms in 100% full extension so that he's not pulling on his joints. And then we get to the bottom and everybody lands and all goes well.
Listening to the movement of the leg.
Okay, so that's the video. And just to summarize a little bit, when we talk about best practices, certainly we want to follow the manufacturer guidelines. As I said earlier, partner communication is truly essential. The stair count, really out loud. We were recently teaching a class of high schoolers and encouraging them to talk really loudly to one another so that communication was clear. We know that there's so much external noise around, especially when you're outside on the street. So going down, let's say on that stoop, all you need is one fire engine going by and a partner doesn't hear the other partner. So, the counting is essential. the lower EMT gives the count going when you're going down, going up. It's generally the upper EMT. Again, this practice may vary depending on your organization and how you handle it. And then what really is essential, as I mentioned earlier, is taking pause breaks for muscle recovery. When you're sustaining a muscle contraction for a long time, the muscle can fatigue. If the muscle fatigues and then there's a high demand, a high exertion level, the muscle can tear, even micro tear. So we want to make sure that if someone is feeling something, and you're out in the field and you're going down those stairs, and if you look at the bottom picture here on the right side, this is, there is a landing. I don't know if they if they are going to take a break. I think they're going up in this one, but I can't remember. And um, if they take the break, they have a chance to just get some muscle recovery. They don't take their hands off the stair chair, but they can release one if they're in a stable position and then, shake it out for even a micro break, just a microsecond, just to get some recovery and then to switch to the other arm. It's, reciprocal, and, allowing both partners to do that. And it's very helpful, especially in preventing aches and pains, but certainly in preventing a full-blown injury. So we're going to do a quick audience poll just through the chat. And I'm going to ask if you would answer this question of how have you sustained an injury on the job? Have you missed at least one day or more of work from an injury? That would be from back strain, neck spasm, ankle sprain, pick your injury. And if you could just say yes or no in the chat. We just want to get a sense of who's in the audience if you have any experience with injury. I see those numbers popping up. Thank you. That's great. So what we're seeing is, hold on. We've got a few no's. Yes, back pain. LOL. I don't think probably weren't LOLing when you got the back pain. So I see a bunch of yeses, another low back pain, another back pain, um, some shoulders and knees, and a bunch of yeses and a few nos, which is great. And someone no and really glad about that. Shoulder and bicep strain, more low back. This is great. This is very helpful. It's also helpful for us as educators to really know, that what we're spotting as the vulnerabilities really are. Thank you for that. So we do know that at least even in this audience, that maybe 50% may have had something that kept them out of work for a day from an injury that was sustained at work. So, we don't all want to be patients, but somehow that seems to be what happens for some reason or another as we stay in our fields or as we get older. So this is not a poll question, but this is just a personal insight question for you. A lot of people, the question is your physically demanding job making you stronger? And I'm not going to put this into the chat. I just want you to think about it because what we find when we go out to talk to first responders, to nurses, to construction workers, people in a loading dock. Most people in the theater industry, most people think that if their job is physically demanding, they become stronger daily. But interestingly enough, when we were teaching high schoolers in an EMT program recently, their response was, well, you probably get strong to a certain point, but then if you don't maintain it, you won't stay strong. And really, it's a question to ask yourselves. If you got to a point of physical strength that you want to sustain, what are you doing to sustain it? Because you won't keep getting stronger and stronger and stronger unless you really make that a priority and work on that personally. Because we all bring some sense of personal risk to our jobs. Many have a predisposition for injury in terms of their body type. People who are very, very flexible may be more prone to musculoskeletal injuries. The level of experience, which we talked about earlier in the statistics. But really, we focus on the injury history and physical condition, which are definitely influenced by stress level and lifestyle. So if your injury history shows that you had a torn meniscus, or if you had a basketball injury from high school and it's still always there, just a little bit, or you feel it when the weather changes. And then also, what kind of physical condition are you in? So we like to highlight those and to encourage you to pay attention to your injury history and also to think about what you're doing in order to maintain a good level of physical fitness. And then, really, if you are hurt or if you are injured or if there's something that's not going away that happened on the job or elsewhere, what do you do? How do you know how severe the injury is? Why go for rehab? Why go for PT or OT? And then how do you prevent an injury reoccurrence? So we bring this up not because we think you don't know, but we want to encourage you to really, if you do feel something that is not going away, early intervention is key. Get it looked at. If you notice something's not going away at night or you're waking up with it, if your knee's bothering you, get it looked at because chances are it's vulnerable. And that's why going for rehab is important. And oftentimes you'll get a home exercise program. Oftentimes it's a minor injury. That's really what we hope. And then you can strengthen it and you learn how to get stronger around that area in order to prevent a reoccurrence of the strain, sprain, or a full-blown injury. So finally, in terms of the fitness component, for another day, we can talk about the details of all these areas, but really individual physical fitness will help your physical and mental health and can prevent injuries. And this is an overarching statement that would include aerobic exercise, stretching, strengthening, and self-care. And these are the categories that we look at and encourage you to look at in order to stay strong, stay fit, and really be fit for your job because you are essentially athletes out there. And we know what athletes do to stay strong. So we encourage the same. And now I'll hand this off to Michael Gormley, my colleague. Michael?
Good afternoon, everyone. Happy EMS week from a former EMT. So my part here is about injury reporting. We get those little cuts, sprains, bangs. We should be reporting all that, documenting it somewhere. So why would we report them? So it identifies increased areas of risk. The more reporting is out there, we have near misses, we have reports that the information is compiled, so where the powers that be can say, hey, this is a problem here. Maybe this rig, this ambulance, or maybe this step, or maybe this kind of a handle on a door is hurting people, so we can actually try and improve it and change that. So this, reporting highlights areas for system improvement. Every year we go to these fire shows, EMS shows, and we see all the different stretchers, the different handles, the different means of egress and get into rigs, all the back restraints we have, all the wonderful seat belts that I was actually working in Harrisburg on to restrain us. Sometimes they will hinder our work. So as progress comes on, maybe we can have some seats that slide forward. But the problem is we're trying to start IVs or starting to do work on patients while the rig is moving. And with uncertain traffic and traffic lights and people walking across and bicycles, sometimes rig has to slam on the brakes. We need to be protecting ourselves with the straps, with positioning, with whatever seatbelts are there. We should be wearing them as often as we can. It's reporting, it supports and protects employees. If it's not documented, not reported, it never happened. You get a cut on a call, a week later you report it because you have an infection and you work a second job at a different EMS agency or you work in a store, so they're not going to say, oh, well, okay, we'll cover it. They're not. They're going to question this. So every time you get an injury, document it. Even if it's a text to your boss or text to the lieutenant or whoever's in charge, captain, I text them, hey, this is such and such. I got a cut on the rig. I washed it down. I just want to make sure it's documented. And for your protection, but it also reveals patterns and trends, like we said earlier. What's going on, like as we have the figures from back to 2017, I think, Arlette, with the injuries. We compiled all that data, we looked through it, took out some of it, but put up the major injuries, like the knees. Yes, they are the weakest part of us. We go into dire situations. We go into different, like the wonderful video we had was at BMCC. Wonderful stairs. We don't always get those. We get narrow stairs, winding stairs, landings. We have to maneuver the patient. They may not be as cooperative. Someone said it could be an EDP. Yes, they will lash out at you sometimes. The elderly people going down the stairs in a reeve stretcher, you think you're going to drop them, so they're holding on to everything they possibly can. And you're trying to push and they let go and you fall. So things like that we have to be aware of. Am I changing the slides or are you doing the left? Thank you. Let me see. Ambulance safety. So entry, egress, rear, and side of ambulances. Definitely most of these doors open into the street, so we have to look both directions. I know Mount Sinai has some rigs that will drop down to the ground or on the airbag system, but they'll lower down. Let them lower down. Let the doors open all the way. Use the handles that are there. Even though you look at every rig, the handles are pretty much the same. There may be different colors. They're all designed pretty much the same way. You have the rear handles, you have the side door handles. Use them. It should be 3 points of entry and exit each time. So to stabilize yourself, 1 foot down the ground, 1 foot on the step, and 2 hands holding on. You have maybe a 50, 60-pound bag and you have a monitor on you. If one of those swings, it can take you off balance, you fall. So 3 points of stabilization, mostly when you get out of the rig and in. I would talk about sudden stops and accelerations. It'll fling you from the back of the rig to the front. Reaching for equipment. If it stops, rib fractures, back strains, neck strains, leg strains when you're trying to stop yourself. All these things you should be watching and be aware of. And of course, we're trying to take care of the patient. You're number one, then the patient, unfortunately, is number two, because if you get hurt yourself, you can't take care of your patient. That's why we encourage the seatbelts, positioning, have the equipment, even with the designs of the rigs. If you have a say in the design of your rig, have the most essential equipment close by, like IV start kits, stuff like that. Have it set up so you can actually just pick out the bag, do what you have to do. And sometimes if it's a trauma, of course, the place is a mess. When you're done, you're trying everything to save this person's life. If you start an IV, you can have an IV kit there. But if it's a respiratory issue, you can have the respiratory kit there. You hook into the oxygen, so you're not standing tripoding over the patient trying to get all the equipment that you need. Mental status of the patient. Yes, we have had incidents where we've taught classes where EMS personnel have discussed getting injured. I myself worked in the psychiatric hospital for quite some time. And it's very real. These people are faster than us. They're thinking ahead of what we're doing. We don't know what is in their mind. They maybe think you're an animal chasing after them, especially like, extreme EDP patients on their medications. They look at you as someone who's trying to kidnap them. They're trying to hurt them. And they're not lashing out at you. They're lashing out at something. So we be aware of this. If communication, again, like as someone said, communication is key. Even communication to the EDP patient. Hi. My name is Jess. I'm here to help you. Oh, my name's not Jess. I just saw Jess there. But I'm here to help you. What is your name? What can we do? Sometimes, breaking that stalemate between you is what's going to get this patient to actually work with you. Next slide, please. So moving, lifting, and handling and the patient handling. Assessment is key. It's not just a patient assessment, it's the totality of your surroundings. What do you see? You walk into a building, you walk up 10 stairs, you go to the left. Have you been to this building before? Is it a state-run home? Is it a hospital area? Is it a rehab? What is it? Is it a business? Is there chemicals in here? So you have to be alert for smells and bells, basically. You find something that smells really bad and the patient's inside on the ground and you're like, oh, wait a minute, what is this bad smell? Oh, it's methyl nasty. We just have to clean it up, but it's all over the patient. Please take him out. The patient must be deconned before they go in your rig or get to get to the hospital, but they must be deconned as soon as possible. That patient is not a priority. The priority is deconning and getting the chemicals off the patient because you're bringing to the hospital in your rig, which is has to be deconned. You bring him into the triage area, into the main hospital, and he's off-gassing certain chemicals. You got a problem. So surroundings is a very, very important thing to watch out for, when you go into the back of a building. How far back? How many doors did you go back? Like, how many flights of stairs did you go up? How many flights of stairs did you go up? Did you go to the basement? So always, hey, listen, I don't like, we made 2 lefts, we made 2 rights. Count in your head. Look at plants. Look at whatever you see around you. Like, so you can get back out into situation raises that you have to get in a hurry. You have to leave everything behind. You know how to get out. Again, communication with the patient. Determine their mental status. Are they drunk? Are they high? Are they angry? They're having a bad day. Are you having a bad day? Maybe you're not the person to be talking to the patient. Maybe it's your partner. But definitely assess the patient's mental status before you continue. And then we do a physical assessment, head to toe. Did they fall? What happened to them? Like, what led you to be in this situation at this time? Why are you there? Did the patient fall 6, 8 feet? Is it level of trauma? What is it? Maybe the person just needs a Tylenol. They want to go to the hospital for a Tylenol and a sandwich and a diet ginger ale. So we then have to determine the best way to get the patient out. Sometimes the patient can walk out. Sometimes they have to go on a stretcher. Maybe you have to use the backboard temporarily, maybe the reeves, maybe the scoop, maybe the stair chair, depending what you have. You're going to figure this on your way up. If you can't get the stretcher into the lift, or you can't get up the stairs, then it's going to be a reeves, it's going to be something else. Determine the transfer type. What are you going to do? If the person's on the floor, how are you going to get them up? If they're stuck between a wall and a toilet, how are we going to get them up? The last thing we want to do is injure the patient. Get ourselves injured, but injure the patient. We're not there to be the bad guys. So what are the challenges? Well, removal of patients from tight and awkward areas. Again, how many times do you find them stuck between the toilet and the bathtub, or between a big heavy bed, or the place has, you have to walk sideways to get up and down the corridors because they're lined from floor to ceiling with magazines and papers and boxes. Even the person, they could be in the bathtub. Are they covered in soap? Are they wet? Like, you have to determine a lot of this stuff. And then again, we go to extrication, vehicle extrication. You roll up on the scene, and you have to assess the situation, find out what you got. What is there? Is there chemicals involved in this accident? What is that red stuff? Is it jelly? Is it blood? Is it a chemical? So even if it's a motor vehicle accident, you approach with caution. You have to look around. You have to make sure that you are safe. Scope your path, identify challenges, and communicate. And somebody even said earlier today, the key is communication. Definitely is. If your partner can't hear you, they can't hear you. They don't know what you're saying. Trying to tell them that something is wrong, and you say, well, something's wrong. They're not going to hear you. So communicate what you're doing. You've got stairs, you got curbs, you got ramps, uneven terrain, slippery surfaces. Look at the streets out there. They're awful. You can break an ankle on the street just walking by yourselves. The roads are all torn up from salt over the winter. So, hey, you tell your partner, hey, there's a hole there. Rather than them find it by themselves, and you hear that crack, and now you got 2 patients. The lead is the person who's in charge of the directional basis where you go. So if you're dragging the stretcher behind you, you walk into a door and you see something, you stop. Hey, we got this. Hey, we got that. There's an open elevator shaft. Like, let's not walk down there. Things like that. So the lead person is the one who's doing the communication. But you got to listen. You got to stay off the phone, stay off the radio. The radio is not important. Neither is your phone. If you have to text somebody back, text them later. Get the job done. So again, avoid the cell phone. Use the radio when it's appropriate. When you're moving the patient, if you have to answer a call, they'll call you again. And again, attention to the scene. You'll pull up on the scene sometimes, and it could be a CPR in progress in a house, and the family have this idea that when they call 911, everything's going to be okay, and the person who is not breathing anymore is going to be fine. It could be a drug overdose. You never know what it is. You could be going to a drug house, and they're not happy with you because it took you 10 minutes to get there because of traffic. And now they want to know what you're going to give. They're going to give Narcan. The Narcan didn't work. Well, why is this? And they get angry. So you have to make sure that what you're dealing with, like, watch the crowd. Watch the crowd for that one person who's going to challenge you and everything you do. Even a person who has that camera out, you can't stop them. If somebody wants to videotape you on scene, you really can't stop them from doing it, and just let it go. You're better to look professional in a video than someone putting up on YouTube that you're yelling. Oh, the EMT was yelling at me. So be professional, ignore it. It's not your job to take care of that. Even if they're taking your picture, they're taking a picture of the patient. That's something between the family and them, but you're not going to take the camera from them, you're not going to stop them. So let it alone. Again, avoid splitting your team. Sometimes it's necessary. Sometimes you have to split. So like one person had to go for something, but you have to make sure that it's safe. You just can't say, okay, go get this, and in the middle of a brawl. So again, it comes back to communication. Okay, we need to get this part out of the rig. Can you go get it? If you're not that far away, maybe we can bring the patient to the rig and take it over there. So you have to think how you are going to handle this situation. And we have other environmental considerations. So some of us are EMT, EMS. I'm out here in my town. We got in the snowstorms, you do all sorts of stuff in the winter. So wet weather, mud, leaves. We have that in the fall. We have it during the first good rainstorm of the year, washes all the salt away and reveals all the rubber that's been on the roads for the last couple of months. Black ice and rain, we get that. We had it not too far, about a month ago. We had it, black ice. It's rough to drive in. Due regard is what you have to do. You can't be going 15, 20 miles over the speed limit. Again, you have motorcycles, bikes, pedestrians, and runners. I walk down to the city on those little blue bikes. I don't know how many times I often get run over because I don't realize that these things are not going to stop for the lights, and I'm just going to, and this guy's flying past me, and you see people get hit, people die. The problem is too, they pull out in front of rigs. They think, okay, it's got lights and sirens, but I got rights too, and I'm going to go out in front of them. We lose a lot of people every year. It depends on the investigation, what is handled. You could be held liable. Just because you have lights and sirens and your lieutenant saying, go through the light, doesn't mean you have to, because you're the one with the license, you're the one driving. So if they say, go through the light, go 15, 25 miles an hour, you don't have to do what they say. You have to drive with due regard. Low angle surfaces, again, walkways, driveways, where cars drive up into buildings, into garages in the city, they get covered in ice, rain, nasty dog poo a lot of times too. Just your uneven surfaces, anything that's going to cause you injury. Next, please. Are you taking this one, or am I doing it?
Okay, yeah, thank you, Michael. That was great. Yeah, those city bikes are really a challenge, whether you're in front or behind or in a car or a pedestrian or a bike rider. We just see this all the time. So in closing, as we move toward the end of the webinar, one of the things that we want to encourage all of you who are here today is to think about how to build a team safety culture. Chances are your organization talks about safety all the time. The question is how to create this as a team culture, how partners look out for one another and others who are subbing in for the day, or how it can be in the front of your mind. And what we have found, and we've spoken to so many and been out in the field, and we know this from our acute hospital injury work as well. I know this from the ED, working in safe patient handling with the nursing community. It's really about the communication, the way to create strength in a safety culture is by people who work together, speaking to one another, and also speaking to your managers if you have concerns about anything that's related to safety. I've the rule of 10, which is that if one feels it, then chances are there are 10. And then, of course, you can look at that exponentially and say, well, if 10 feel it, then maybe 100. So don't assume that it's just you if you have a safety concern. And to really feel comfortable to share and report, not to be embarrassed about any near misses. Something almost happens, that means the next time it could happen. And it's not about you, it's about the scenario, or it's about the perfect storm. It's about the time when a few things converge and there is a safety incident. But we can take apart those incidents and analyze them and look at how to decrease the risk in terms of a safety matter. Ongoing education on injury prevention. We are very committed to this, and we do feel, because we do so much education, that it's not just sitting in a 1 hour webinar in EMS week, but it becomes an ongoing awareness and learning and reminder of best practices and buddying up with your organization and with those that you work with other employees or volunteers, to really think about what you want to learn about and to make that happen. Certainly, you're welcome to contact us about anything related to education. And we do workshops where we're working in a real lab scenario, where we're simulating what goes on out in the field. Again, to do it not when you're under the gun, under pressure, but when you can really problem solve together, speaking with your managers, and then ask questions. If you have a personal challenge and you have a manager or supervisor, director, bring it to them. And you never know what kind of amazing things happen when you ask a question. The way this program, the EMS injury prevention program, evolved at Mount Sinai in the EMS department is, they came to us at the Centers for Occupational Health, Selikoff Centers, and they said, look, we have this many injuries. We know everyone has their moment that they do get hurt, but we're trying to figure out a way to bring the number of the injuries down. And we certainly set the benchmark and the goal for bringing the severity of the injuries down, because we know you're in a high risk profession, and that certainly there are ways that we can create some degree of protection and awareness. So, we encourage everyone here to think about EMS injury prevention and then to encourage your organizations to have a program. It fills a void. There really is very little out there. That video that you saw is one of a few that we have started to shoot so that we can use it for education. We're under a grant from the Department of Health in New York, and we are going to be sharing that and then offering up, to come out to work with you. Having an injury prevention program boosts confidence. It's also a self-care aspect. It's like, well, my employer cares about me. They're really investing in helping me not get hurt. It also increases awareness of injury risk, but more importantly, looking at the solutions and what you can do to avoid the risk factors, and shared strategies for daily practice. And you can talk about it. I know it's not what you talk about at lunch, but sometimes it's really helpful to problem solve as a group. And we think the most important part is that, it really destigmatizes the reporting of injuries and incidents. So many are afraid to say, this happened to me, maybe even to the point where they won't report it. But the idea is that reporting can be helpful. Reporting, as we started out this talk today, is reporting can help to improve the quality of your program. It can protect everyone. And also it helps to build that safety culture that we talked about. So this is where we end, and I'm going to ask all of you participating today if you can scan in the QR code so that you can do an under 3-minute survey that will be for the CME and for your participation. It's really quick, and then we will take Q&A. Jess, how are we doing with questions?
Yeah, I see a few coming in. Let's see. So it looks like some people are wondering, what can they do to combat bad posture, especially that you get from sitting around in an ambulance all day?
Okay, that's a great question. So first of all, forget about what your parents told you as a kid, which is you have such terrible posture. Really, terrible posture. As a kid, most kids don't sit up straight, and they don't know how to sit up straight. So don't worry about that. And compromised posture is something that you can work on. What we do in our workshops is to really emphasize the importance of core strengthening as a launch point. Breathing, core strengthening, and we get into some of the details of getting on the floor. Many of you may be familiar with bridging and tilting your pelvis on the floor, called a pelvic tilt, for lower back stretching and then abdominal strengthening. There are a host of things you can do to work on your posture, but really, if you have a strong core at the foundation, and working on your glutes, believe it or not, it's not just about the abs, the part that you see, it's also about what's going on behind you. So doing buttock squeezes. And the nice thing is that when we do our workshops, we talk about how you can do abdominal strengthening when you're sitting in the ambulance. You can sit there and you can contract your abdominal muscles, and you can actually talk while you're doing it as well. And we do practice it. So it is important. And we start there and then we work up. There's and sometimes you can find a really great video of wall angels, which is upper back posture, really focusing on your lats and your rhomboids. Those are the upper back muscles. I'm sure everyone here knows anatomy. And really what we're trying to do is to promote upper back strength and bringing the shoulders back and then bringing the head over the shoulders while you're working so that you remain in more of a neutral posture. With that, I want to say is that you can have very strong muscles, but if you don't engage them, then it's kind of a bust. So it's really good for you to think about that before you do the lift, that really you want to anchor yourself with engaging your muscles, and that will really help. I can't go into, I don't have a lot of time, so we'll go on to the next question, but certainly you can be in touch with us about that.
Thank you. And so any thoughts on nutrition? I see some people concerned about that maybe eating junk food during the day could increase their risk of injury.
Yeah, the sugar highs and the sugar lows and the explosive running down the street and moving very quickly after sitting for a long time. We get this question at every webinar, and we're thinking about putting together another webinar that focuses on nutrition for first responders and for those in similar professions. So if there is interest, please let us know. We do, as a basic tenet, really encourage you to eat an easily digestible, well-balanced diet. The junk food doesn't really help. And the sugar crashes do create a fatigue situation. We do encourage you to eat well and stay in touch with us so that we can find out if a nutrition webinar is something of interest. And definitely put in the chat if there is interest. Thanks, Jess.
Thank you.
I think we have time for one or two more if we have.
Yeah, I think last one. Anywhere that people can go to learn more about strengthening?
So going back to the first question, which is about strengthening, it becomes it's really full body strength, right? But it's not just about strengthening. Just don't forget that it's also about stretching, because the most effective muscle contraction comes from a muscle that can lengthen and shorten. I mentioned earlier, I'm also a rehab therapist, and what we know is that muscles can only perform if they have the fiber stretch and the length that they need to have in order to really get a most impactful contraction. So they go hand in hand, and certainly flexibility for the joints, and some aerobic exercise. For strengthening, we do some of that when we teach our workshops. It's really hard to do it here and now, but I'd say, again, go back to the core, look at the foundation, your abs, your glutes. And I cannot emphasize enough that, your thighs, your thigh muscles, having tight hamstrings is a surefire way to get an injury if you trip on something. So you want to make sure you're well stretched in your hamstrings and also having strong quads. Basically, what I'm saying is you need to be strong everywhere. And it's not just the muscles that you see, not just those biceps, but you need the triceps to balance the biceps. And certainly to look at your posture. Where is your head? That's what I say to people all the time. Where is your head? Is it over your shoulders? Because you don't want to create a neck injury as well. But certainly you can email us more specific questions after today's webinar. I know it's really a juicy question. Thank you. Is that all we have, Jess?
Yes, I believe so. I think that brings us to
Okay.
the end of our session.
That's
Thank you everyone for joining us today, and thanks again, Arlette and Michael.
Thank you. And thank you, Jess, for the partnership of Mount Sinai EMS. We'll be back with more, everyone.
All right. Take care. Happy EMS week, everybody.